Hi, welcome. I put up a study guide on asthma, what you need to know for your NCLEX and nursing school exams. What is asthma? Asthma is an acute inflammation of the airway, especially the bronchioles, from the immune system overreacting against a trigger. Asthma is reversible once the inflammation is treated, as compared to COPD, which involves permanent changes in the airway. Imagine a trigger which could be an allergen, infection, smoke, exercise, stress, or even some medications like NSAIDs and non-selective beta blockers. NSAIDs like aspirin, Motrin, beta blockers like propranolol. Once the allergen gets to the bronchiole, it triggers an inflammatory response. The soldiers come prepared. The likes of eosinophils, mast cells, lymphocytes, they start fighting this trigger or allergen with so much rage, causing damage to the walls of the bronchioles. The bronchioles get inflamed, swollen, and narrows the lumen of the bronchiole. The inflammation also triggers mucus glands to go wild, producing tons of thick mucus that blocks the lumen even more. This narrowing or bronchoconstriction causes air trapping and difficulty with breathing out, and that's why you will hear expiratory wheezing in the early stages of asthma attack. Let's pause for a second. So, who do we not recommend to take NSAIDs or beta blockers, especially non-selective beta blockers? Asthma patients. So, they can have a question that tricks you that the patient has asthma, a moderate to severe. You give them they have a headache or whatever, then they want to take Motrin or they want to take an aspirin for some sort of reason. It's a no, no, no. Is asthma an obstructive or restrictive lung disease? It is an obstructive airway disease because there is obstruction of air or CO2 from moving out of the lungs. Asthma patients struggle more with breathing out than breathing in, just like in COPD. However, we do not classify asthma as chronic obstructive disease because it's reversible. Once you take a bronchodilator, take corticosteroids, the inflammation goes away and the airway is back to normal. Can chronic and controlled asthma look like COPD? Yes. This is because over time, with repeated inflammation, which happens in uncontrolled asthma, the airway remodels, scars up, and starts narrowing permanently. How does the patient with acute asthma look like and sound like? Coughing a lot, chest tightness, difficulty with breathing out. So, initially they breathe faster and they are so tachypnic because they are trying to compensate, and breathing fast helps expel CO2. And you might see respiratory alkalosis because of the expulsion of the CO2. But once they get tired, they start breathing normal or bradypneic. These symptoms, for some reason, are more prominent at night. What is status asthmaticus? This is a medical emergency because the airway completely clamps down. No air movements in or out of the lungs. Silent chest or auscultation. Status asthmaticus. It is a severe life-threatening asthma exacerbation that does not improve with standard treatments like short-acting bronchodilators, the likes of albuterol inhalers. Status asthmaticus requires immediate aggressive interventions to prevent respiratory failure. The early signs of status asthmaticus includes tachypnea, which is compensating for the buildup of CO2 in the body. This leads to respiratory alkalosis in the early phases. You will also see tachycardia as the sympathetic fight or flight mode has kicked in. Loud wheezing, use of accessory muscles, anxiety, and agitation, which are early signs of hypoxia in the brain. What are the late signs of a status asthmaticus? These are signs of impending respiratory failure. Something has to be done very quick. Fatigue, the patient is tiring out and stops to compensate. Bradypnea or decrease in the respiratory rate as they blow out less CO2, they start to go towards respiratory acidosis. On auscultation, you will hear a silent chest, meaning no air movement in or out of the lungs. They get cyanotic, starts to turn blue, altered mental status, meaning at this point they cannot protect their airway. They need immediate interventions, including intubation. So, how do we treat status asthmaticus? First of all, patient presents then an exacerbation of asthma. First things first, give them oxygen, give them a supplement, usually BiPAP to maintain oxygen more than 94%. We also give them high-dose, short-acting beta agonists, like that's the SABAs, the albuterol, levoalbuterol. Continuous nebulized albuterol is preferred in severe cases. We can also give them anticholinergics or synergistic bronchodilators like short-acting muscarinic agonist, the SAMAs. The famous one is the ipratropium, which is added to SABA for additional bronchodilation. So you have albuterol and the ipratropium working together to help with bronchodilation. Same time, you can also give systemic corticosteroids, IV methylprednisolone, to reduce inflammation in the airway. If everything else is not working, we go for magnesium sulfate IV. Magnesium helps to smooth the smooth muscles in the bronchioles to relax, and is used usually when you have an unresponsive initial bronchodilation. We can also give epinephrine IM for severe bronchospasms or in anaphylaxis, if anaphylaxis is suspected. Remember, it's allergens that trigger all this. Then we can also give, if the patient is not responding to just a nasal cannula or a face mask, we can go to non-invasive ventilation like BiPAP, and BiPAP helps with expelling out that CO2. If all things come to an end, we have to do intubation, mechanical ventilation, which is the last resort. And this is indicated when the patient has altered mental status and they cannot protect their airway. Thank you for watching, guys. If you enjoy my content, kindly subscribe, share, and comment, like my videos. And thank you for now, and I'll see you on the next one. Bye.